Good morning, for people who bothered to show up. So glad you're here. Let me just close some windows down. Matt Bernhardt shows. That's a good day. When Matt Bernhardt shows up, it's a good day. Ariana Totarum, you are the only person for whom I've looked at your hexamethonium quiz, and you got it right. There was one that might not have been right, but most of it was right. I see your faces, so as long as it's just us. God, 4 people. What the hell? Mike West still needs a haircut. Ariana, you haven't moved since, God, August at least. Aren't you getting hungry? You gotta get around, girl. Tyler Montano showed, yay, Tyler. Trinidad, am I right, Tyler? Trinidad?
Yeah, correct.
All the way from Trinidad. See? No, I knew I could count on Noemi to show up. Bum, bum, bum. Okay. Well, why don't we go ahead and get started? 1, 2, 3, 4, 5, 6, 7. 7 people. Wow. That's like a record. 7 out of 20. How many in this class? Maybe 10 or 12. Okay, let's do this monkey thing. So these are Ariana's answers, and I hope she doesn't mind me sharing them, but they're all very good. And since I'm sharing them, I don't have to actually think. I can just read what she wrote, which is also good. Okay, hexamethonium. This is an interesting drug I learned about in grad school. Hexamethonium is a drug that blocks nicotinic receptors in both the sympathetic and parasympathetic ganglia. So this doesn't affect the neuromuscular junction, it just affects the ganglia, but both ganglia. So we're just basically cutting off the autonomic nervous system. And if you look this up, just for the hell of it, you probably should. It might even be in your Moodle page, but it's a whole long spiel about what this person's life is like. And I think this was actually used for hypertension at one point before there were better drugs. This is a pretty crappy drug. But hexamethonium, he is pink complexioned person, except when he has stood for a long time, when he may get pale and faint. Why is that? Well, controlling your blood flow and where your blood is going is all about the sympathetic nervous system. He would be pink because his vessels would be relaxed, a lot of blood flow to the skin, because the only control is sympathetic, and if there's no sympathetic control, the vessels dilate and a lot of blood goes to the skin, so he's got pink complexion. But if he stands too long, all the blood pools in his legs and he faints. Because normally your sympathetic nervous system would contract the vessels in your legs and force blood further back up. His handshake is warm and dry, warm for the same reason, vasodilation, so he's got more blood in his skin, dry because the sympathetic nervous system causes sweating and there's no sympathetic nervous system. Your rudest story will not make him blush. It's because he's kind of a jerk. No, I'm just kidding. Rudest story will not make him blush because he can't blush, right? He's already pink. He's not going to get more blood to his face. It's interesting, too. The older I get and the more woke I get, the more I realize everything from the 50s and 60s was about white people. There's nothing here. Like, how can you blush if you've got a lot of color in your skin already? I don't know. But anyway, rudest story will not make him blush, and the most unpleasant circumstances will fail to make him pale. So he's got no control over the blood to his face, even unknowingly. So socks and his collar stay clean and sweet. Again, he's not sweating. This is the one that I wasn't crazy about Ariana's answer for. I won't show you her answer, though. He wears corsets and may, if you meet him, be rather fidgety. So corsets to bind around his middle, squeeze his middle to get more venous return, get blood back to his heart. and fidgety, again, to get more venous return. He is long-sighted and easily blinded by bright light. So your autonomic nervous system's controlling the size of your pupils, the sympathetic opening, parasympathetic closing, and it's also controlling the focus of your lens. You contract you squeeze the lens and it changes the focal length. So you're constantly long-sighted. You can't focus close. Okay, so that's hexamethonium man. And there are a couple other questions down here that I don't think were all that interesting. Yeah, so we're not going to worry about those. But I think since only Ariana answered it, I'm not going to give, here, I don't think we're going to give any bonus points for it because really she's one of the few people who did this quiz, so no bonus points. Sorry, Ariana. You're not going to be mad. You're supposed to be mad when I say that. No, about 6 people did it, and I will give bonus points. I'm just trying to be a jerk, and you're not letting me. It upsets me. Okay, so I've been feeling bad recently because my lectures have been really, really short. I think this one's going to go a little longer. This should be at least 45 minutes. This is the first in my series of pathophysiology lectures. So when you think about it, so far you've gone over intimately the cellular mechanisms, right? What's causing contraction in the heart, smooth muscle, and what happens when the receptors are activated, what phosphorylation targets there are that change the function of the heart and everything. And if you step back from the cellular mechanism, step back, you're looking at the heart, you've got ventricular muscle, you've got atrial muscle, which are pretty similar, but then you've got the electrical tissue. So we've talked about the cellular mechanisms of that and electrophysiology of controlling the contraction. And then, and also the autonomic nervous system controlling the smooth muscles of the arteries and veins and the heart itself. Stepping back from that, you've got the whole autonomic nervous system. So pretty much, you should know everything that controls the whole cardiovascular system at this point. And that's kind of important from a pharmacological perspective. That's the thing about pharmacology. It includes everything because anywhere along there could be an opportunity to make a drug that's going to affect these things, right? So if you're a biochemist, you might, spend your whole life looking at the ATPase in a myosin head and how it changes the conformation of the myosin head. Very narrow focus. With pharmacology, it's a lot more broad. It's like you're concerned with hypertension. All this stuff is involved in hypertension, and you can find or make drugs that will interdict in different places. So that's the thing about pharmacology, is so broad. And again, I started this class off talking about why you might want to be a pharmacologist. This is one of them, in that it gives you a more broad understanding of physiology and things like that than the very narrow focus sometimes of something like a cell biology. So anyway, enough of that. I'm sure you're all going to be pharmacologists someday. Okay, so hypertension. What is this the first slide really? Nope, there's the first slide. Okay, what is hypertension? It's chronically elevated blood pressure. So another story, my whole life is stories. My father used to drive me nuts because, up until the last couple of years, he had hypertension. And so his doctor said, you should get one of those blood pressure cuffs, the automatic ones, so you can just check your blood pressure on a regular basis. So he did. And so he'd go into the kitchen, grab it, walk into the living room, put it on and say, oh, Jesus, my blood pressure is really high. And he'd sit there for a minute, try it again. Oh, look, it came down. Wait another 10 minutes. Oh, it came down again. There's something wrong with this cuff. It keeps changing the numbers. It's never the same. Dad. Tried to explain to him when we say blood pressure, what we're talking about is your resting pressure. And that's why a lot of times when you go to a doctor's office, they sit you in the room and they sit you there alone for 10, 15 minutes before the nurse comes in and takes your blood pressure because, walking around raises your blood pressure, especially your systolic, but also your diastolic. Remember, we saw norepinephrine effect increasing both diastolic and systolic even more than diastolic. So any kind of movement or whatever changes your blood pressure. So when we're talking about chronically elevated blood pressure, we mean at rest. And typically they're taking it in your arm, and they want your arm to be level with your heart, because then you don't have, like if your arm was down, the blood would be going down, and that would increase the pressure before it hit the artery that you're measuring the pressure in. So you want to be sitting up and have the blood pressure cuff level with your heart, and you want to sit there long enough to let your autonomic nervous system just kind of mellow out. But anyway, if it's chronically above 140/90, that's definitely hypertension. Now, we talk about different stages of hypertension. Over 120 is kind of mild, and also with the diastolic. And then over 140 is definitely hypertension, then we have to start changing things. Diastolic is always more important than the systolic. Your systolic will go up if you're nervous. Your diastolic is important for perfusion of the heart. And we'll talk about that today. If this is elevated, then your heart is in a lot of trouble. Okay, and you could also have isolated systolic hypertension or isolated diastolic hypertension. And if you want to know anything about the heart, the best place to go is the American Heart Association, because they've got all the best data, and they're really good at making things for the public. So it's easy to understand, and everything's good. Okay, so anyway, systolic versus diastolic. Normal is less than 120, less than 80. So they've kind of dropped this. It's always been 120/80 is normal. Now they want you a little bit lower than that, but mine's always like 125/83 or something, and they let me go. So elevated is when you get over 120. Hypertension is when you're at 130 over creeping up on 90 for your diastolic. Hypertension. So stage 1, we're going to talk about lifestyle changes. Stage 2, now we got to do something about it. 140/90 on a chronic basis is bad for your heart, for a lot of things. And then hypertensive crisis is when you come into you're like, uh-oh, what's going on? You go to the emergency room, they're like, oh, you're 180/120. We have to get your blood pressure down now. Okay, that's the crisis. And I know at least one condition that'll give you that, and we can talk about that later. So anyway, bottom line, American Heart Association, American Stroke Association, these people have the best numbers. Risk factors for hypertension: diabetes. Okay, diabetes means you've got elevated sugar, elevated glucose, and glucose is another osmotic suck, right? So you've got extra sugar in your blood, and that brings water out of your urine, your blood volume goes up, and you've got hypertension. Obesity, I'm not sure why, but that also increases your blood pressure. And that's the thing with getting back to my dad was pretty big at one point. I think he should have been about 180, but he was up to 240. He got pretty fat, and that's when when his blood pressure was high. And then when he got older, he lost a lot of that weight, and then he was in hypotension because he was still taking his blood pressure medication, and he no longer had hypertension. So obesity is a really, really good risk factor for hypertension. Also, lifestyle things, smoking, right? Smoking, nicotine, activating your sympathetic nervous system directly at the ganglion, increasing blood pressure. Drinking too much, 1 or 2 glasses a day is great, actually, for your cardiovascular system. 5 or 6 a day is going to give you hypertension, and it's a bad thing. Sedentary lifestyle, right? No exercise, and being stressed out all the time is also increasing your blood pressure. So type A personality, I don't know if you guys have heard this before. This is kind of like an 80s thing. I don't know if they still talk about it, but we talk about a type A versus a type B personality. Type A people are kind of always on edge, always excited, working hard, moving hard, just, very uptight kind of people. Type B people are like a laid back, yeah, I'll get to it when I get to it kind of people. So type A personality tends to have a higher blood pressure. And ethnicity, African Americans tend to have hypertension We'll talk about renin insensitive or whatever, low renin hypertension. And it's not really understood why. There was an idea, a hypothesis once, kind of came out in the early 90s about how the whole Middle Passage, when slaves were picked up in Africa and then put in the holds of these ships, and they're just packed like sardines, and the slave traders would expect, 25, 30% of them to die on the way, and they drop them off the side of the boat. And the hypothesis was that the people who survived were had a greater ability to reabsorb salt from their urine, so they had a better ability to conserve salt. Turns out that's not true. It had nothing to do with that. But I mean, it was a hypothesis that people thought about at one point. But if you look it up, and if you hear, the reason I'm telling you this is if you hear it, it was a hypothesis, but there's really no data to support it. So that's not true. Okay. Oh, and here are your risk factors again in cute cartoon form. Being overweight, unhealthy diet, too much alcohol. I wouldn't say alcohol use, I'd say too much alcohol. Low physical activity, smoking, stress. Some medications will have as a side effect hypertension, and we'll talk about that. Certain chronic conditions, we'll talk about some of those. Low vitamin D, age, getting older, family history of hypertension, gender, I'm not sure what they're getting at there, but obviously it's important. And then pre-hypertension, which is what young people would have, like a pre-hypertension that would predispose you to getting it later. Okay, causes. There's two different kinds of hypertension. Primary hypertension, which is to say that your problem is hypertension. It's not secondary to some other problem. Secondary is where you've got some underlying disease and that's causing your hypertension. So the main thing though is primary hypertension, because 95% of hypertension is this. They don't really know why you're hypertensive. It's just that we know you are and we need to do something about it. So it usually starts between 25 and 55 years old. I'm 57, so I'm good. Hypertension, possible causes. One possible cause is the hypersensitivity or hyperresponsiveness of the sympathetic nervous system. So we know sympathetic nervous system increases blood pressure by increasing cardiac output, by increasing total peripheral resistance. So if your system is overreacting, then you're going to have higher blood pressure. Increased renin, angiotensin, aldosterone response. So you remember that was our last, what is today? Tuesday? I think it was last Thursday. Yeah, Thursday we talked about blood volume control. So that's out of control. And a decreased sodium excretion is another possibility. I'd like to editorialize too, if I could. The American Heart Association, everyone says decrease your sodium intake, but if your kidneys are healthy, they can handle the excess sodium if you put a little salt on your food. Some people are salt sensitive, and that's probably 30%, a third of the population. Their blood pressure is going to be really affected by how much sodium they take in. But for the average person, sodium uptake is not that big a deal, in my opinion. Don't tell your mother I said that. Okay. Primary hypertension. Decreased sodium excretion is one cause of primary hypertension, especially in elderly who've got less kidney function, right? All your organs get older, including your kidneys. So the elderly will decrease their sodium excretion, and also African Americans, for whatever reason, we don't understand why. And this is what they call low renin hypertension. So normally, if you're reabsorbing a lot of sodium, it's because you've got renin, which is producing angiotensin 2 downstream, and then that increases aldosterone. You get an increased sodium excretion. This is not that. This is just kidneys are excreting less sodium, and that increases your blood pressure, and increasing your blood pressure decreases renin release. So you've got low renin but high blood pressure. And ACE inhibitors, which are one of the drugs we'll talk about, are not going to work in this type. So ACE is angiotensin converting enzyme. So if you remember from Thursday, renin converts alpha globulin into angiotensin 1, and then angiotensin converting enzyme converts angiotensin 1 into angiotensin 2. So if you inhibit that enzyme, it's not going to work because, it's not your renin. Renin is not the problem. Secondary hypertension. Is that all I said for primary? Oh, okay. Yeah, okay. So this is the fourth one. I'm sorry. So basically primary hypersensitivity, increased renin, decreased sodium excretion, and then here's a special case of decreased sodium excretion when it's not renin associated. Okay, secondary hypertension. We've got a lot of possibilities here, but this only represents 5% of all hypertension. But the nice thing about this is if you solve the other problem, the blood pressure comes down. So usually these are younger patients, not your elderly, but your younger patients, and they've got some kind of disease. And I'm just giving you some of them here because there's a lot of rare diseases that cause this as well. First and most obvious, kidney disease. If you've got problems with your kidney, then you're not excreting sodium and water, so your blood volume goes up. So an example of this is renal parenchymal diseases. So the parenchyma is what's outside of the loop of Henle, and it's impinging on the loops. Glomerular nephritis, so inflammation of the glomerulus. Diabetic neuropathy, which I don't know what that is. Infection, which is going to cause inflammation as well. Polycystic kidney disease. If you want to see some really gross kidneys, do a Google Images search for polycystic kidney disease. I saw this one picture, and I didn't want to make you look at it, but a kidney is usually about like this. And it was a picture of two kidneys that were removed from a patient, and they were like this, these huge, massive things, and they were all just cysts. Okay, so here is your glomerular nephritis. So you've got inflammation in the glomerulus, and that's going to inhibit its ability to filter. And then this is polycystic kidney disease. So basically, cysts are growing between the nephrons and squeezing them so they don't work anymore. Oops, not what I wanted to do. Hang on a second. Okay. Okay, secondary hypertension. Another cause is renal vascular stenosis. So Thursday we'll talk about cardiac stenosis or coronary artery disease, and that's when plaques build up in your coronary arteries. This is plaques building up in the arteries that lead to the kidney. So you get less blood flow to the kidney, which decreases glomerular filtration. Vasculitis, an inflammation which also narrows the arteries. Fibromuscular dysplasia. This is kind of a weird, you'll see in the next picture, but it's kind of a weird way of also decreasing blood flow to the kidneys. So renal stenosis is like plaque building up on the inside of the artery to the kidney. So that we'll talk about more in terms of the heart, but it also happens here in the kidney. Here is fibromuscular dysplasia. So in my cancer class, I don't know if any of you took my cancer class, but I talk about dysplasia there, which is basically cells are just growing too much. They're not invading, so they're not cancerous, but you're getting too many cells. So that's kind of what you have here. The smooth muscle cells are proliferating, so you get a really thick wall to that afferent arteriole. And so that restricts blood flow, and less blood flow to the kidney means less filtering and less ability to lose sodium and water. So again, you've got all these kidney diseases that can cause hypertension. So that's usually one of the first things they look at, make sure your kidneys are okay. Endocrine disorders. So they'll do a blood test and check your endocrine enzymes. So increased aldosterone, which is called Cone syndrome. And increasing aldosterone means you're going to retain more sodium. Increased cortisol will do the same thing. These are both mineral corticoids, meaning that they increase the reabsorption of minerals. And cortisol also, in addition to causing more resorption of sodium, increases your adrenergic sensitivity. So remember, cortisol is your stress hormone. So when you're really stressed, you put out a lot of cortisol, and that kind of upregulates your sympathetic nervous system to get you ready for this stressful situation. Chronically, it's not a good thing. That's why stress long-term was one of our risk factors. A lot of stress will cause you to have hypertension, and this is part of it because your cortisol will sensitize the sympathetic nervous system. And here is your adrenal gland. So you got your cortex outside, medulla inside, and we've got different layers of the cortex here. So I don't expect you to memorize this. I just wanted to have a picture to show you. I hate PowerPoint presentations that are all words. So I thought, let's break it up a little here. So your cortex then is the most outer part of the cortex is where your aldosterone is coming from. But then you also have mineral corticoids, including cortisol coming from deeper into the gland. But again, who cares? Medulla, we'll see this in a minute, puts out epinephrine, norepinephrine, and dopamine. So, here it is. Secondary hypertension, endocrine disorders, increased norepinephrine and epinephrine. So this is another problem that your adrenals can cause where you get pheochromocytoma. So this is a cancer. And it's also one of the few diseases that's actually in iambic pentameter, pheochromocytoma. So actually iambic tetramer or whatever. Anyway, so your adrenal medulla has grown too big, so it's putting out tons and tons of norepinephrine and epinephrine, and your blood pressure goes up, 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 up. And so this is one of the things that will give you that hypertensive crisis I talked about in one of the early slides. So you come into the hospital with a blood pressure of 210 over 120, and they do a check and they find out you've got tons of catecholamines in your blood. First thing they do is hit you with phenoxybenzamine. Who remembers what phenoxybenzamine is? POB, phenoxybenzamine. I've been talking about this one pretty much the whole class. Yeah, nobody knows. Okay. So irreversible antagonist of the alpha receptors. So the first thing they're going to do is hit you with POB and block those alpha receptors and bring your blood pressure down. Okay, another endocrine disorder is hyperparathyroidism. PTH increases, parathyroid hormone, and that increases calcium in your system. As you know, calcium is important for the contraction of arteries. So your external calcium goes up, you get more calcium coming in, more contraction of the arteries. So here's pheochromocytoma. So the medulla has just gotten huge, and now you're putting out too many catecholamines. Here's parathyroid hormone. So this is your thyroid, right, which is in your throat. Parathyroid are these couple of bumps here, and here's an enlarged one. So you've got too much parathyroid hormone. So anyway, in terms of endocrine disorders, we've got Conn's syndrome, aldosterone, Cushing's with cortisol, pheochromocytoma with catecholamines, and PTH giving us too much calcium. Okay, and more endocrine disorders, thyroid disorders. This is kind of counterintuitive and interesting for that reason. Either hyper or hypothyroidism will give you hypertension. Hyper makes a lot of sense because the thyroid kind of upregulates your sympathetic nervous system just like cortisol does. So it's kind of stimulating you, so you get more peripheral vascular resistance from your sympathetic nervous system. Hypothyroidism, on the other hand, increases sodium retention. So this is kind of interesting in that here's your autonomic nervous system control of blood pressure. Here's your blood volume control of blood pressure. So hypo, they both cause hypertension. And here are kind of signs and symptoms of hypothyroidism, thyroidism versus hypo. Hypothyroidism, kind of you're tired and you lack your stamina and motivation. You're kind of depressed, mood swings, hearing loss, blah, blah, blah. Hyperthyroidism is the opposite. So this is kind of like type B versus type A personality. Type A personality, they're kind of nervous, breathless, difficulty sleeping, kind of on edge all the time. And one thing that's a really good clue to this hyperthyroidism is usually their eyes are bulging out. They literally bulge. So that makes diagnosis easy, I would imagine. Secondary hypertension. Internal, this is a weird one, pretty rare. High intracranial pressure. So you've got some kind of head injury and your blood pressure spikes, and that's because of this Cushing's response. And then, here's something I never worry about, pregnancy. Pregnancy, if your blood pressure is high after 20 weeks, they call this preeclampsia, and you really got to be careful about this because the woman could die from eclampsia. Eclampsia happens during birth. Preeclampsia is like before birth. High blood pressure plus proteinuria, protein in the urine. So the seizures here and eclampsia will cause death. So that's something you really need to keep an eye on. I'm not a doctor, but I think in general they try to avoid death. Medications. Combined oral contraceptives, the estrogen and progesterone contraceptives can cause elevated blood pressure. Sympathomimetics, CNS stimulants, block norepinephrine uptake peripherally. So sympathomimetics, we're talking about amphetamines and cocaine, right? They're going to block the norepinephrine reuptake, and so that'll increase your blood pressure. But also something like phenylephrine. I mean, let's see, about a year ago, I think it was, I had a lot of nasal congestion, and I went to get some pseudoephedrine, and I accidentally got phenylephrine by accident and started taking it, went to the doctor and like, oh my God, your blood pressure is so high. What's going on? I was taking phenylephrine. That'll increase your blood pressure because it's a sympathomimetic, alpha 1 agonist. But in general, mostly we're talking about amphetamines here and other recreational drugs. Antidepressants, like tricyclic antidepressants and SSRIs. So your tricyclics are inhibiting the breakdown of norepinephrine. So that's going to cause more norepinephrine in the nerve terminals and therefore more release, and that can increase your blood pressure. It's good centrally because that's going to give you the stimulation and get you less depressed. But peripherally, it can cause hypertension. SSRIs, same thing. They're supposed to be blocking the reuptake of serotonin, but they do have some affinities at norepinephrine as well. And there are some SSRIs that are norepinephrine specific, and that can give you high blood pressure. Okay, so those are all the things that can cause hypertension. What happens if you have hypertension? So for me, this is a more important part of the lecture here. Like what causes it, it's all just memorization stuff. Here's kind of the more thought process based things. So this is more like what I would ask you on a test. So what happens if you have chronic hypertension? One thing that can happen is ventricular hypertrophy. So, whenever you work a muscle, it gets bigger, right? Skeletal muscle does that, cardiac muscle does that too. So you're overworking the ventricle by increasing the afterload, right? It has to push harder to get blood out. And, the amount of cardiac output is related to not how hard it is to push out, but what your body needs. So your heart, if it's pushing against a higher afterload, it's going to push harder because you have to make that metabolic need. So it's going to work harder. And as a result, it's going to hypertrophy. And hypertrophy means you're thickening that ventricle wall. So it sounds like a good thing. We got a stronger heart now, but it's not, because the thickness of the wall tells you how easy it is to fill the vessel or the ventricle during diastole. So if you've got a thickened wall, the ventricle isn't as stretchy anymore. which is going to decrease your end diastolic volume. I'm sorry, wait, escape. Oh, shit. End volume diastolic. What the hell am I thinking about? End diastolic volume. Okay, sorry about that. Okay, so you're decreasing how the ability to fill that ventricle, which decreases the end diastolic volume. When you decrease the end diastolic volume, you decrease your stroke volume, which decreases cardiac output. Okay, and that's so which means you're going to have to use some of your cardiac reserve just to meet your normal metabolic needs. So now you've gotten your heart into a hyperactive state and you can't stimulate it as much. So your reserve has decreased. So here's what happens in our stroke volume curve. Here's a really thick ventricular wall. It should be thicker than the right side, but the left side should be this thick. So what happens? See how steep this curve is. Remember this curve down here. This is the filling of the ventricle. Volume's increasing this way, and it doesn't really slope up much because it's stretching out really easily. And as it stretches, it can contract harder. Here's with a stiffened wall, it's much steeper. So for the amount of time of the diastole and the amount of venous return, you don't get as much blood into the ventricle. And so now you start to contract, isovolumic, and then isotonic. And so this is your stroke volume now from this red line to this. So your stroke volume is decreased. And so cardiac output decreases and blah, 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 blah. Okay. Complications of untreated hypertension, 2, congestive heart failure. So with all of these things that we have going wrong, all the pathophysiology, all leads to congestive heart failure eventually. So CHF is when the heart muscle gets weaker and weaker, and usually it's dilated because the muscle is weaker and weaker, so it ends up getting bigger and bigger. And this is how eventually you die from heart disease, is by congestive heart failure, typically, unless you take a massive heart attack all at once. So anyway, congestive heart failure. Hypertrophy leads to inefficient pumping, which leads to decrease in cardiac output. So if you decrease your cardiac output, well, your body still needs that oxygen, so sympathetic nervous system kicks in, which is going to increase your blood pressure more. And if you remember that paper we read, one problem with chronic sympathetic stimulation is you get hyperphosphorylation of the ryanodine receptor. So in that paper, we saw that chronically stimulating it, or they had exchanged a serine for an aspartate so that it looked like it was constantly phosphorylated. That causes that ryanodine receptor to be leaky. And when it's leaky, you lose calcium from inside the cell, and that decreases the contractility of the heart. So overstimulating the heart with sympathetic nervous system causes it to kind of decompensate, right? So increasing stimulation is compensating for the fact that cardiac output is decreasing, but you do that too much, you decompensate, so it gets worse and worse. And this is why, paradoxically, a beta blocker will help in this situation, because it's going to decrease your cardiac output, but it's going to stop this overstimulation. Okay, also, here's another problem with hypertension that's going to lead to congestive heart failure. So this is kind of like another way you're screwing up your heart with high blood pressure. When you increase your high blood pressure will increase the ventricular diastolic pressure, okay? So high diastolic pressure means that you're getting less perfusion of the heart. So perfusion of the heart means, if you look at the heart, some of the first vessels that come out, you can't even see them here, come out and feed the heart itself. Okay, so the first vessels off the heart come back and feed the heart. So the heart needs blood. When does the heart get fed? Only during diastole, because during systole, the muscle is contracting so hard, blood can't go through it. So the only time your heart is getting oxygen is when it's in the relaxed state. You increase the ventricular diastolic pressure, you increase the wall tension during diastole, you get less perfusion during diastole. So you get less perfusion, which is ischemia, to hold back blood. Ischemia results in hypoxia, right? Less blood means less oxygen, and you end up with cell death. So the problem here that's leading to congestive heart failure is you're making your heart work harder and giving it less oxygen. So you're going to end up with cell death, and that weakens the wall, and you get a weaker heart. And that's what congestive heart failure is, a weakened heart. Coronary artery disease is also caused by hypertension, and we'll talk about CAD on Thursday. But basically, it's plaque growth in the coronary arteries. And why does hypertension lead to this? I don't think they really know. I think it's phenomenological. They know it happens, but I don't know if they know the mechanism. At least I don't. Could be just that the hypertension is causing endothelial cell damage, because endothelial cells on the inside of the vessels are protecting the smooth muscle from being exposed to what's inside the blood, because there are, like growth factors and things inside the blood that the smooth muscle shouldn't see. So if you lose endothelial cells, those smooth muscle cells can grow into the vessel, and that's part of coronary artery disease too. But I'm kind of making that up. I don't really know why high blood pressure causes coronary artery disease. I just know it does. And the problem with coronary artery disease is, again, ischemia, right? You've narrowed the vessels that are leading to the heart, and so you get hypoxia and cell death. And again, increasing work, decreasing oxygen. Okay, so here is coronary artery disease. And again, we'll talk more about this later, but it's like these plaques building up inside the coronary arteries. And this is actually a heart attack, because you've totally blocked off this vessel with a clot. And that's one of the big complications with coronary artery disease that we'll talk about Thursday. Once you've really narrowed this down, you make it more vulnerable to total block. And once you totally block that vessel, all this heart muscle dies. So here you can see everything below the block dies. So and that weakens your muscle because you've got fewer cells there. Okay, complications of untreated hypertension. So another thing is, if you've got plaque growth in your carotid arteries, and this happens a lot in older people, your carotids are feeding your brain. Same thing with the heart. As with the heart, if you don't get enough blood to your brain, you end up with ischemic strokes and dementia. So hypertension can lead to a stroke in this way. Again, building up plaques in those arteries, and then it clogs off, and then, the parts of your brain die. And also dementia, just less blood, less oxygen to your brain, and you start to lose nerve cells, and you start to be demented. Okay, aneurysm is another danger of hypertension. So you've got a lot of pressure in that vessel, and as a result, a weakened part of the vessel will then balloon out. And this is a saccular aneurysm, a sac, and this is fusiform. It's basically the whole vessel has ballooned out. And the big danger with that is it can rupture. And when it ruptures, the blood just pours out. So if that happens in your brain, that's another type of stroke, hemorrhagic stroke. And if it happens in your aorta, a lot of times people with chronic hypertension will have an aortic aneurysm. If that dissects, boom, you're dead. You're dead like in seconds. All your blood rushes out of your aorta and into your thoracic cavity, and you just drop to the ground and you're gone. So aneurysms are really dangerous. And then there's kind of the general thing we call end organ damage, which means all the organs that are being fed by this blood at too high a pressure end up getting damaged. So blindness, right? Retinal damage from high blood pressure in your eyes, and kidney damage, which, once you start having kidney damage, you increase sodium retention and your hypertension gets even worse. So these are all the things that hypertension can lead to. So how do we end up not getting hypertensive or fix hypertension? First, lifestyle changes. So especially if you're at that mild to moderate hypertension, the first thing you want to do is try and straighten your life out. Exercise is really good for decreasing your blood pressure. And they say, for me, exercise is getting on the machine and sweating for an hour. But even just walking around, taking walks instead of sitting on your butt is good exercise, and it makes a big difference. Stopping smoking and drinking too much, right? Obviously, if that's what's causing it, you stop doing that. DASH, which is a diet to something hypertension. see how much I learned this week. Diet, I don't know, diet to stop hypertension, basically. So low in sodium, right? A lot of people are sodium sensitive, a third of the population, so get rid of sodium. Diet rich in fruits and nuts. I don't see nuts here. Nuts count too. Vegetables. So these are all with the polyunsaturated fats and things like that, which are better for your blood, for whatever reason, decrease your blood pressure. Whole grains, low dietary fat, lean protein. So getting fats out of your diet can bring your blood pressure down as well. And then just relaxing, biofeedback and relaxation techniques. And these things like yoga and stretching exercise and breathing exercise and meditation, these things activate your PNS, your parasympathetic nervous system. My brain originally went to peripheral nervous system. No, that's not right. Parasympathetic nervous system. And that will decrease your blood pressure. Okay, so what happens when you tell your patient to do all these things and they don't? Then you go to drugs, okay? And the first line treatment, you remember by ABC. These are your first line treatments. A's, the first thing they always go to is ACE inhibitors. You're blocking that conversion of angiotensin 1 to angiotensin 2, which is going to decrease your aldosterone as well as decrease the pressor effect of angiotensin 2. Again, remember, old people and African Americans, this doesn't necessarily work. But for most people, this would be your first line of defense. And some examples of drugs: captopril, enalapril, lisinopril. Here's something I learned in pharmacology way back in 1988. If they rhyme, they do the same thing. Drugs that all do the same thing tend to rhyme with each other. Okay. Second line of defense, beta blockers. Okay, decreasing your heart rate, which is going to decrease your cardiac output. Also, decreasing contractility, which is decreasing cardiac output. So we're bringing the system down. Propranolol is, a guy won a Nobel Prize for that. That was like the first beta blocker, and it was used for hypertension. Non-selective though, can't be used for people with asthma. Some beta-1 selectives are metoprolol, atenolol, and acebutolol. Again, notice they all rhyme. Calcium channel blockers. Okay, so this is causing direct vasodilation. So these are binding to that voltage band of calcium channel and smooth muscle. And, that's really important for contraction of the muscle. So you're blocking that, and you're causing venal relaxation. And there's really three classes of calcium channel blockers. They tend to put two together, but these are very different drugs. The first class are your dihydropyridines, DHPs. Nifedipine, nitrindipine, amlodipine, isradipine, anything ending in pine is a dihydropyridine. And these are really more vascular selective. These don't have much effect on the heart at all. Remember, you've got the exact same voltage band of calcium channel in the smooth muscle as in the heart. Big difference is in the smooth muscle, the membrane potential is about -50 normally, right? In the heart, resting membrane potential is about -70. So that makes a big difference for dihydropyridines. They're more likely to bind to the channel at a more depolarized voltage, so they have more effect on the arteries than they do on the heart. Your non-DHPs are verapamil, diltiazem. These are, again, two different drugs, but there's only one drug in each of these classes. And these are are also going to decrease your blood pressure, but they're going to be a little more cardiac, have more cardiac effects. They will affect the SA node to decrease heart rate. They'll remember that the depolarization, the upsweep of the depolarization of the heart is voltage dependent calcium channels. So your DHPs aren't going to affect that channel, but the verapamil will decrease heart rate and also decrease the conduction velocity through the AV node. Same thing with diltiazem, more so verapamil, but also diltiazem. Okay, so your D of the ABCD is another one these are all kind of frontline defenses here. The D is diuretics. So diuretics induce sodium loss, and when you lose sodium, you lose water as well, decreasing blood volume. The classic diuretic are either the thiazides or the loop diuretics. So if you go back to our last lecture, we were looking at the ascending limb of the loop of Henle. When it's coming up, that's where you're actively excreting sodium into the parenchymal tissue. You're blocking that. Sodium stays in the tubular fluid, which increases water retention. Loop diuretics, furosemide. I'm not sure what this is doing, but it's also blocking sodium retention or sodium reabsorption or something. So you end up with more sodium in the fluid, and so you're losing water as well. Furosemide is the classic one that they give you if you have a lot of peripheral edema. First thing they'll put you on is that. It's called Lasix is the trade name, and you'll be peeing every half an hour until you get rid of that fluid. It's really a really strong diuretic. Diazides are more chronic for chronic hypertension. Okay, so that's your main line of defense, and ACE inhibitors, beta blockers, calcium channel blockers, and diuretics. Other treatments. So there's a lot of other things. We've gone through a lot of these mechanisms already. So just looking at all the other things that we can inhibit blood pressure with. Alpha blockers, right? Prazosin is a really popular drug. It's an alpha-1 selective antagonist. I should have put it in here. Oh well. Alpha-2 agonist. Remember, the alpha-2 is the presynaptic alpha receptor. You activate that, you decrease norepinephrine secretion or norepinephrine release and contraction of the arteries. Angiotensin 2, remember, angiotensin 2 does two things. One is a direct pressor effect, contracting arteries and also causing aldosterone release. Block those receptors, you get neither of those effects. Nitrates, like nitroglycerin, right? Nitroglycerin is used more for coronary artery disease. We'll talk about that on Thursday. So coronary artery disease leads to angina. So nitrates are mostly used for that. Nitrates have more effect on the venous side than the arterial side for some reason. Nitrates are going to produce nitric oxide inside the smooth muscle, which then activates cyclic G production. Cyclic G kinase gets active, and then you phosphorylate a bunch of sites and you get relaxation. So nitrates are mainly used on the venous side for some reason, but sometimes they'll give you a nitroglycerin patch long term. Okay, hydralazine. That's another direct relaxer. I'm not sure what the mechanism is, but it directly relaxes veins or arteries. Minoxidil is one that really isn't used for blood pressure, but it's kind of an interesting thing to put in here. Minoxidil causes, it's a potassium channel blocker. So that causes, blocker or opener? Opener. It opens potassium channels, and that causes relaxations of vessels. So it does decrease blood pressure. Mainly what you should know minoxidil for is it fixes male pattern baldness. So usually they use it as a topical thing on your head, and that helps you to increase hair growth. Female pattern baldness too. Women go bald too. On my mother's side, my aunt and her daughter are both balding. You know, but when women go bald, they still have a lot of hair. It's just really, really thin. When men go bald, it's just totally bald. Spirolactone. So one of the things I didn't talk about with the loop diuretics over here is with both of these, you're putting more sodium. You're keeping more sodium inside the fluid, right? Inside the tubular fluid. More sodium inside activates the sodium potassium, not pump, but like a antiporter. So when you save sodium, you're losing potassium. So that can cause a big problem. Remember, potassium is really important in your blood to keep your membrane potential right. So you can end up with a lot of arrhythmias if you have low potassium. So if these things cause you to be low potassium, they'll put you on spirolactone because it's called a potassium-sparing diuretic. So it's also a diuretic, but you don't lose potassium like you do with the other ones. So I believe that's it. Yep, that's it. Okay. So we went through a lot today. I mean, I spent a whole hour talking to you people. That never happens. Can I see your faces real quick? Noemi, Nicole. Tyler's not going to come, I know. Tyler's video doesn't work. All right, guys. Well, I don't really have a whole lot else to talk to you about today. Do you have any questions about today's lecture? I think I went kind of fast. We went over a lot of stuff. Is there any questions, comments? Nothing? Wow, I'm an amazing teacher, aren't I? It's like I just say it once and y'all know it. Okay, so here's your homework. I want you all to send an email to the dean and tell the dean I deserve more money. Okay, because I'm a good professor. Okay, that's your homework, and you each get a bonus point, 1 bonus point for each email you send. Send as many as you want. Vote early, vote often. Speaking of, get out there and vote if you haven't already. And if you have voted, as long as you're voting for the right guy, vote again. What the hell? Just kidding. All right, guys, that's all I got for you today. Be careful out there. Another virus going around.